Thank you very much. It really was a very kind introduction, and I'm very pleased to be here. I've been spending the last 2 years at the March of Dimes, and I have to say that this is an organization that I'm very proud to be associated with, and I'm proud to say that 98% of Americans know the March of Dimes. The question, of course, that some of us have is, do they remember the March of Dimes for our former work or for our present work? You know, the organization began in the first half of the 20th century when one of the polio victims, an affected member of our society who happened to be President of the United States, Franklin Delano Roosevelt, knew that there were children in iron lungs, knew that this was a serious disease, and he created the National Foundation for Infantile Paralysis. This had a singular goal: to eliminate polio in our midst. And Eddie Cantor, some of you are old enough to remember that entertainer, one night in 1938 on his radio show said, "Let's have a march of dimes. Let's send all those dimes to the President in the White House. Everybody fill up an envelope with dimes and send it to the President." And 2 days later, there was nothing happening at the White House. And everybody was getting a little nervous, except for the President, who really didn't want to cause that stir at the White House. And the next 2 days, the trucks came with about $50,000 in dimes. That began the March of Dimes. And 17 years later, based on research funding, based on the hard work of Jonas Salk, we are all the recipients of that good work, which resulted in the polio vaccine, which has now virtually eliminated polio throughout the world. Not quite, but we're getting there. So this was the first not-for-profit organization in the history of not-for-profits, before or since, who actually solved its problem. And the organization then had to decide in the 1950s and early 1960s, what would it do? And it chose to stay with the basic problems of children, and its mission today is to improve the health of America's children by preventing birth defects, preventing prematurity, and by decreasing infant mortality. And we do that in a multiplicity of ways, each of which I'm going to touch on today. We carry out this mission through research, through community services, through education programs, not only for professionals, but for the consumers and the population at large. And we are serious advocates for the health of America's children and the health of America's women and families. So today I'm going to talk about prematurity. And this collage of pictures is what people think about when they think about small and sick premature infants. Now, I'd like to examine how research over the last 40 years has helped decrease mortality and morbidity, that is, the bad consequences of prematurity in America and throughout the world. But I'm also going to discuss a very serious challenge that we have in 2009, and that is the challenge that prematurity in America is increasing. So while mortality and morbidity decreases, the number of premature children is increasing, and we need further work to change that trend. The birth rate in the U.S. is increasing a little bit at this point, although it's fairly static. We have about 4.3 million babies born every year in the U.S. But some of those babies are born before 37 weeks gestation. Those are the babies that we call premature. Now, you will recall that the normal gestation, as God in her wisdom created it, was 40 weeks. And I will show you some data to suggest that that's changing. But 40 weeks is normal biology of gestation. Less than 37 weeks is defined as prematurity. Now, in the last decade, prematurity has increased 10%, and in the last 20 years, 30%. It's an extraordinary epidemic. It's the #1 perinatal health challenge. It's a leading cause, the leading cause of infant mortality, now actually beating birth defects. And it's the leading cause of cerebral palsy, blindness, deafness, and mental retardation among children and young adults. If we look at the preterm births by gestational age in the United States, and we look at the years between 1995 and 2006, we see a troubling increase. 1 in 8 children in the United States today are born preterm, before 37 weeks, 12.8%. In 2007, that meant 546,000 children born preterm. Now, if we look at the preterm birth rate in Wisconsin, we see that's increasing during that same period of time at about the same rate, although Wisconsin's rate of preterm births is only 11.4. It's better than some states, but worse than others. So if we look at the country at large, Wisconsin, which I hope I can find, there it is, 11.4. You know, I'm this New Yorker guy who, once he gets a little west of New Jersey, is a little in trouble with geography. But Wisconsin's 11.4, and I'm going to show you this slide in the context of the March of Dimes preterm birth report card a little later in the discussion. But the best and only state less than 10 is Vermont. We'll talk a little bit about why we think Vermont wins. We've got lots of states that are worse, and Wisconsin is in the solid middle with a D. I'll tell you about the grading in a minute, but in my house, if I came home with a D, this would be a major life event. So we don't think Wisconsin's doing as well as it could. And here are the data comparing Wisconsin to the U.S., and indeed, in some years, Wisconsin has been worse in terms of deaths due to prematurity than the U.S. as a whole. At present, it's holding its own. Well, I think most of the people in this room know about the consequences of prematurity. The acute consequences, those little sick babies have problems. Those problems are basically due to immaturity of their organ systems and fragility because they are so fragile. That's the fun and the challenge of doing neonatology and pediatric surgery in these little and very vulnerable children. So they're fragile and their organs are immature. They have breathing problems. We call that respiratory distress syndrome. They have heart problems, not only congenital anomalies of the heart, but functional problems of their hearts. Their fluid and electrolyte balance is very complicated. Their kidney function is immature, and they have close to kidney failure when they're born at the threshold of viability. They get jaundiced, the bilirubin levels go up, and these can cause serious problems for these tiny prematures. Nutrition is a great challenge. Infection is common. And bowel problems, one of the most serious problems of inflammation of the bowel, we call necrotizing enterocolitis, can result in a very serious gut problem. And one of our critical problems, which are still mainstream problem in prematurity today, is the problem of brain damage. The very fragile blood vessels hemorrhage in the brain, and other areas of the brain have decreased perfusion of blood, and we have two very serious problems of intraventricular hemorrhage, bleeding, and periventricular leukomalacia, or softening of areas of the brain after the cells have been damaged. These acute problems are the challenges of our neonatal colleagues, and we'll talk a little bit about several of them. But we shouldn't forget that as mortality has decreased, the long-term consequences, the morbidity continues for these children. And those include chronic respiratory problems. Having gotten over the acute problems, sometimes the treatment for those acute problems results in chronic problems for these children in breathing over the course of infancy and then even into their young child lives. Premature children frequently get rehospitalized and have other problems in the first year that need to be dealt with. They have serious neurodevelopmental problems, school problems, and issues around cerebral palsy and cognitive deficits, and even an increase, as we've seen now with some new data, of autistic syndromes and syndromology and symptoms in premature babies. Now, there is a series of centers in the United States that collect data based on NIH funding called the NICHD, National Institute of Child Health and Human Development, Neonatal Network. These data are from the network from 1997 to 2002, in which they pool their outcomes. And we would expect these to be very good data. They're good academic centers. They're not better than your academic center, but they are comparable to your academic center. And if we look at these data on the mortality of the very small babies, we see that the tiny, teeny 1-pound babies survive at a very low percentage. So these are survival data off of 100%. But as we quickly get to the 2-pound babies, we see that those babies begin to survive at 90%, and the moment you get to 1,000 grams, you're at 95%. Now let me put this in some perspective of those of you who were alive in 1973. 1973, not everybody. 1973 was a very important year in the United States when the Supreme Court addressed the Roe versus Wade abortion controversy, which is still the law in this country. But in 1973, they were talking about the threshold of viability. Now, what they did was they took a statistical number based on 10% survival. And 10% survival in 1973 in the neonatal units of America were 2-pound babies, 1,000-gram babies, and 28 weeks gestation. Fast forward 20 years to 1993, if you go 30 years to 2003, 1,000-gram, 2-pound babies at 28-week gestation have survival rates of 96-7% here, in that range, 95 to 97% around the country. So that short period of time has caused a tremendous change in the mortality and enhancement in the morbidity for these small babies. And I'd like to talk a little bit about why that is. Again, in this neonatal network, if we look at this composite slide, this slide which gives us years of birth, 90 to 91, 95 to 96, and 97 to 2000, we see for the very tiniest 1 to 1.5 pound babies, 1.5 to 2, 2.5 to 3 as we go across, we see that survival without morbidity, survival without consequence for the big babies is very, very substantial and has changed even over this decade. And what's the real issue for these immature babies? Well, we call it respiratory distress syndrome, lung immaturity. Now, for the non-doctors in the room, there's supposed to be an image of a heart in the middle of this baby's chest, but it's not able to be seen because the lungs that are around the heart are supposed to be dark with air in them. These lungs are collapsed with no air in them, and this is the classic picture of respiratory distress syndrome of the immature lung of the premature baby. And this remains a significant problem, but it first became a serious issue in 1963 in this country, when a very important baby was born on Cape Cod. His name was Patrick Bouvier Kennedy, and he was born on August 7th, 1963. He was sent to that large children's hospital in Boston somewhere. Sadly, as this New York Times article showed, the battle for the Kennedy baby was lost only because medical science has not yet advanced far enough. So, respiratory distress syndrome of this large premature baby, of this baby who was 4 pounds, 10 ounces, and 34 weeks gestation, this baby died in one of America's great hospitals. And America needed to ask the question, why? And in 40 years, science has told us why, and science allows us now to reverse this problem. So what did we know in the 1960s? In the 1960s, we already knew that in the immature lung, those little air sacs, those normal alveoli, would collapse when the baby exhaled, because those little alveoli would not be stabilized, because in order to be stabilized, they needed something called surfactant. Surfactant is basically a surface active material which decreases the surface tension and allows for an air-water interface. It allows for bubble formation. And indeed, we knew this in the 1960s. But the best we could provide in the early 1970s were respirators. We could put a tube into the baby's airway, and we could ventilate. We could push the oxygen in. And as we learned more about how to do that, we got more sophisticated ventilators, and we learned that we could even do what was called continuous positive airway pressure. That is, at exhalation, we could keep the pressure there so those little alveoli wouldn't collapse. The respirators got smarter, and we got better at clinically taking care of these babies. We also developed regional neonatal intensive care units, and we developed a program of training of those nurses and doctors who spend their lives at the bedsides of critically ill children in children's hospitals like yours. That wasn't a small part. It was a big part of why these children benefited. As an intern at a major other children's hospital, not in Boston, but in that town, Baltimore, at that children's hospital, the professors professed and the interns took care of the very sickest of babies. And in the middle of the night, there might be a smart resident like Kliegman with an intern taking care of a critically ill baby. That doesn't happen in your children's hospital today. And that doesn't happen in any children's hospital today. So the intensiveness with which we care for our babies matters. But the science was very important. And here's what happened. So we went ahead and we learned something about those alveoli and that surfactant. And we learned that there were these type 2 lung cells, these cells in the immature lung, which was producing this substance called surfactant, which would be secreted into the alveolus and would stabilize the lung. And we learned what that surfactant looked like. We learned that there were phospholipids. One of them, dipalmitoylphosphatidylcholine, was an important, the most important phospholipid in surfactant. It accounted for about 45% of the phospholipids, and we began to understand something about this lipid. And I have to say, when I say we, I actually had the pleasure as a fellow at the National Institutes of Health of working with Philip Farrell, who was actually developing the animal models to look at the specific enzymes and the formation of these phospholipids. And we actually were able to share some of the animal work and publish some of the work which looked at the first enzymes. Now, this is an oh my God slide, and we're not going to go through it, but I do want you to understand that each of these pathways to formation of these phospholipids had to be understood by the basic scientists. And in animal models, we learned about those pathways. And here's that phosphatidylcholine. And here's this pathway from choline. And we even learned that if you looked at the influence on hormonal influences on those enzymes that were forming this important phospholipid, we found that if you looked right there, steroid hormones would increase the synthesis of that surfactant. So the hypothesis became clear that if you could take a specific steroid hormone, give it to a woman who had gone into early labor and was about to develop a premature baby, would that steroid hormone go across to the fetus, cause the fetus to rev up his surfactant, and would that help him? And the answer was clearly yes. And clinical trials, based in the use of probably the steroid hormone of choice here, betamethasone, have continued to this day to be an effective way of treating women who go into premature labor who cannot have their labor stopped. So that we can take 48 hours, give her those steroids, and result in the fetus having a much more minor disease in respiratory distress. So that was pretty good, and we were pretty proud of that work, and that work was the late 70s and early 80s. But then further research showed that it's even more complicated. That's what happens in research. It gets more complicated. It doesn't get simpler, but people get smarter. So we learned the proteins were very important, and the proteins stabilize those phospholipids. And we learned also that you could extract this chemical with its proteins and its phospholipids from animal lungs. And we could take cows and calves, and we could get the surfactant and purify it and make it safe, and we could actually put it into children's lungs. So we went from trying to rev up the synthesis to actually now having a therapy. So if you remember that X-ray with you can't see the heart and you can't see the air in those lungs, that's called atelectatic or collapsed lungs. If you now put an endotracheal tube, a tube into that airway, put surfactant into those lungs, and 45 minutes later, those lungs are those lungs. That therapeutic intervention developed in the 80s with FDA approval in the early 90s revolutionized the treatment of the sickest premature babies, and to this day is a critical reason that premature babies survive and thrive. Those steps in research didn't take very long. Now, we're all in a hurry, but 20 years to 30 years of basic science translated directly into the clinical realm was critically important. Now, I'm going to talk a little bit about, not as much as this, but a little bit about some of the other areas in neonatal medicine in which there have been scientific advances in this same 40 years. Because you know, at your children's hospital, you've got cardiologists and gastroenterologists and nephrologists and neurologists. They'd all be upset if I only allowed the pulmonologists their due, because they were all doing basic science, and they were all enhancing what we know about premature babies, their care and their outcomes. But there's more to be done. So there's a problem with premature babies, and that is they sometimes don't close a little channel that goes from the left side and the aorta to the right side of the heart, where the blood is supposed to go to the lungs. You see, fetuses don't need blood to go to their lungs. Their lungs aren't breathing air. So we shunt all the blood away from the lungs through this little tube called the ductus arteriosus, little duct. But after the baby's born, that duct's supposed to close, because now the blood does have to go to the lungs, and if it stays open, what happens is blood actually comes from the aorta back into the lungs and floods the lungs. So these poor little lungs that are immature and sick now have more blood than they can handle. So they get sick. But during this same time, we learned that there was a pharmacologic way to close that. And we used it. And now surgical procedures are such, and anesthesia and intervention for premature babies is such, that our pediatric surgical colleagues can, in fact, close these ductuses right in the neonatal intensive care unit with, I hesitate to say, simple surgery. Nutrition and growth. One of the great problems for us in the 60s and 70s was these babies were very sick. They frequently couldn't eat orally. And what could we do to maintain their nutrition as they needed to grow and develop? So the whole field of intravenous nutrition expanded. And intravenous nutrition, kind of chicken soup in a bottle that we can put into a vein. The field of parenteral nutrition saved the lives not only of the premature babies, but babies with congenital abnormalities who needed surgical interventions. That work by Dudrick and others, who were pediatric surgeons in Philadelphia, began a whole set of scientific understanding of what is needed by the premature to thrive. And we now have excellent nutrition, both oral nutrition and intravenous nutrition. Now, we still have that problem, necrotizing enterocolitis, that gut problem, and we still see it in 7 to 10% of the very small babies. And we still need to understand better what are the pathophysiologic causes and how can we prevent that problem, because that can be a serious problem for our little babies. And then, you know, when I was taking embryology, we knew something about the brain and its development in fetal life. And at the Albert Einstein College of Medicine, the dean, who just retired, was the man who did all of this work, Dominic Purpura. So trust me, at the Albert Einstein College of Medicine, we knew this. At 20 weeks, if you cross-section the brain, you'd find not a lot of cells. At 35 weeks, you'd begin to see some cells, and the brain would look like this. And at 40 weeks, you'd see lots of cells and the beginning of interaction among the cells, and the brain would look like that. So we knew a lot about the brain from anatomy, but then we began to know more about the brain through ultrasonography. Because if you will recall, babies have a little soft spot, a fontanelle, and we can put an ultrasound probe there and get a pretty good look at the brain on the inside. So having done that, we were able to get good pictures, and we were able to understand a lot more about that disease we call intraventricular hemorrhage and periventricular leukomalacia. We could time it, we could better understand it, but we still can't prevent it. So there are good clinical trials underway, there are things we're learning more about it, but there's lots more to know. So what I've tried to say to you is that prematurity is a fairly complex disorder. It has lots of factors, lots of pathways, and it isn't all one disease. The 1-pound preemie is not the same as the 3-pound preemie or the 5 or 6-pound preemie. It's a set of diseases, and that's why it's such a great challenge. And what I'd like to do for the remainder of my talk is talk about prevention of this problem, not just treatment. So in 2006, the Institute of Medicine published a book called Preterm Birth. This report basically looked at the causes, the consequences, and the role of prevention in this disease. It first really had an astounding finding. The finding was that it costs the United States $26.2 billion. Now, I know it's easy to say billion in 2009. It used to not be easy to say billion. $26 billion a year is the cost of prematurity to America. About $13 billion is the medical care of the acutely ill, premature, and the mother. And then there's all that cost of the follow-up of children who are premature and their needs and their families' costs. And the report said, now look, this is a pretty simple disease. You're preterm if you go into spontaneous labor, if your membranes rupture and then you go into labor, or if somebody causes you to be born. Now, we call that iatrogenic. Iatrogenic isn't all bad. Some iatrogenic prematurity, in fact, is very good, life-enhancing, life-saving, and important, because sometimes the mother is ill, sometimes the fetus is ill, and that fetus is better off in the neonatal intensive care unit than in a mother who's ill or in an environment where the fetus can't be well cared for. The report also said that there's few pathophysiologic pathways to starting labor. We know that the maternal fetal endocrine system, focused in both the pituitary gland and the adrenal of both the fetus and the mother, has something to do with initiating labor and its abnormal initiation. We also know that infection and inflammation plays a role, and it doesn't have to be clinical infection. It could be what we call subclinical infection, not a rip-roaring fever and infection, but just the inflammation responsible for the beginning of labor. And we also know something about hemorrhage and clotting that causes the initiation of labor and ruptured membranes. And we know quite a bit about pathological uterine distension. You don't have to have 8 fetuses in a uterus to have a large uterus. You can have 2 or 3 or 1 with pathological amounts of amniotic fluid and distension of the uterus, and that will cause the uterus to go into labor. This work from Roberto Romero in Detroit basically says the uterus has 3 phases during the pregnancy. First, the uterus is quiescent, so-called phase 0. It's quiet. Fetus is happily growing inside of a quiet uterus. And then, based on perhaps uterine stretch, perhaps that fetal brain-adrenal axis interacting with the maternal axis, it increases some proteins, and it increases some receptors in the uterus. So the science is getting clearer as to what starts uterine activation. Those proteins, prostaglandins, oxytocin. And then labor commences. And then uterine stimulation occurs as those proteins increase, uterine contractility increases, the cervix opens, the membranes may rupture, and the baby is born. But it's fascinating to me how little we actually know about this normal process of uterine life. And we know even less about the pathologic processes. So infection placed into this situation may not just speed up the course of labor, it may actually start it. And it may cause going from quiescent to uterine stimulation without going through the natural process of labor initiation. And we're only beginning in 2009 to understand what has been not well understood heretofore, arguing that we need much more science in the normal and abnormal physiology of the human female. So how about risk factors for preterm labor and delivery? Well, there are a lot of them. And you could probably think of a few more if we stayed here long enough, and I'm not going to go through each of these. But I do want to talk a little bit about genetic predisposition, because we do know that the recurrence rate of preterm birth is about 20%. So if you've had one, you are at the highest risk of having another. And good science has allowed us actually to develop a therapeutic intervention that can decrease the recurrence rate by 60%. The drug 17-alpha-hydroxyprogesterone is not yet FDA approved, but virtually everywhere in the country is now used by maternal-fetal medicine experts and about 40% of general obstetricians in order to prevent recurrence. And we're now learning that there may well be some genetic markers in women who have a high incidence of preterm birth, and that means that we may at some point be able to screen women and find out which women are at risk for a first premature baby, which means we might be able to do clinical trials with this same drug to see if this drug can impact on those ladies as well. So good science with translational work ends up in better outcomes. The Institute of Medicine said there should be selected priorities for research, and I'm not going to go through this listing, but that we know where the winners are. We know where the work needs to be done is the take-home message. Now, there's one very serious problem of social inequity in the prematurity story, and that is the problem of the rate of African American or black population prematurity. It is much greater, 14% as compared to 12.7 in 2005. And what's interesting, it isn't just poverty. Because as we correct for that, and as we see our affluent African American population, we still have an increased rate among the African American population in the United States of prematurity. And we do in Wisconsin as well. I thought I would bring you that statistic. 17.6% of the African American population in Wisconsin have premature births in 2005. Those are the last data from the CDC that we've got. So this is a serious social and health inequity. There's been some work by social scientists on this issue. And in fact, Michael Liu, an obstetrician gynecologist, public health expert, along with Neil Halfan at UCLA, has thought about this concept of life course perspective. And they argue that there are positive and negative forces that impact on people's lives as they get older. Thinking that we can undo all the negative forces in the short term we call pregnancy, thinking that prenatal care can impact dramatically on all the things that have happened to a woman from the time she was a fetus until she gets pregnant, is naive at best. So what Liu and Halfan are saying is that we need to think about the life course perspective. We need to look at women's health and adolescent health and young girls' health as a continuous issue if we're thinking about reproductive health. And that although prenatal care is necessary, it may not be sufficient to solve the problem. And interestingly, on the science side, we now have a biobehavioral model of how external stressors like racism, like poverty, like poor nutrition, like chronic stressors, can actually affect the neuroendocrine system, the immune system, and the vascular system, and result in preterm labor and delivery. So we're not just talking about social events or psychosocial factors. We can actually look at how that impacts on the biology of reproduction. That will allow us, while we await the society's appropriate interventions to solve some of the social inequities, that may allow us to intervene with biologic approaches that may be helpful to prevent some of the social inequities. Now, I do want to share with you some of the problems about late preterm birth. If we look at 2005 and we look at the weeks of gestation from 32 through 37, and we take a look at 34, 35, and 36 weeks, we very quickly see that that is the vast majority of the preterm babies. So we've now given that a name, and we call it late preterm births. And if you look carefully at the data, about 72 to 75% of the births are these late preterm babies from 34 to 36 and 6/7 weeks. Now, I have to admit, as a recovering neonatologist, that in the 1980s and 90s, I would say to an obstetrician, just get the baby to 34 weeks and we'll send the baby home. You'll remember I showed you the data that 90 to 95% of those babies in the 80s and 90s were going home, and now more than 95% of those babies are going home. Now, I didn't mean it was preferable to term. It was preferable to 28 weeks. It was preferable to 26 weeks. But we have a whole generation of obstetricians who think, or thought before 2006, that 34 weeks was fine. And there was no problem. Well, we know better now. We know better now. But the problem with our obstetric colleagues is that they did something very interesting, and I alluded to it a little while ago. So some epidemiologists, and some of my best epidemiologists are friends. There's one good one sitting in the back there. We looked at all the births in the United States, 1992. Take 4 million, put them on a curve. They know how to do that. Then we looked at 1997. It's interesting. That curve looks a little different. It's moving. Then we looked at 2002. And son of a gun, the curve for the average time for delivery in the United States moved from 40 weeks to 39. Now, this was not evolution. This was intervention. So we had many millennia to get to 40 weeks, and we had 1 decade to get to 39. This is the intervention of new obstetric practice. This is the intervention of the planned delivery. Nobody goes into labor anymore. Now the question is this good or bad? Well, the NIH decided they needed to actually take a look at that, and they generated a consensus workshop in which they looked at these 34 to 37 week babies and asked the question, are they okay? And the answer is they're not. And the epidemiology is very clear that the outcomes are poor. 6 times more likely to die in the first week of life. 3 times more likely to die in the first year of life. But it's still a small number as compared to full-term babies. But when you begin to drill down on the respiratory disease and the readmissions to hospitals and the long-term outcomes, which we now have a series of articles coming out of the U.S. and internationally to tell us that these children have more learning problems, more cognitive impairment, more difficulties in school, more attention deficit disorder, and that these children also have the problems of their prematurity, quite evident in the 34 to 37 week babies. So we need to address the question of why. Well, the practice of obstetrics has changed. And one of the things is that clinical management has changed. To the credit of our obstetric colleagues, they are more aggressive at getting babies out of uteruses where they don't belong. And in the story of diabetes, and the story of preeclampsia, and the story of the diseases that affect women during pregnancy, our obstetric colleagues have gotten more aggressive, and we've gotten better outcomes. But we're now seeing diagnoses like impending preeclampsia. I don't know what that means, actually. I know what preeclampsia is, and I know how to diagnose that. I don't know what impending preeclampsia is, but we're seeing that diagnosis. We're seeing the diagnosis of impending macrosomia, big baby, so we should get it out. And we're seeing obstetricians doing early deliveries. And we know that one of the reasons is our litigious environment. It's not easy to practice obstetrics now. We know that 9 out of 10 obstetricians are named in at least 1 lawsuit, and over the course of an obstetric career, 2 to 3 lawsuits. And that doesn't mean they made mistakes. It means they were named. But no doctor likes to be named in a lawsuit that questions their competence, that suggests they were negligent. So we know that there's a cost when doctors are under tension about that. And that cost is defensive intervention, because you rarely get sued for doing more. And there are other reasons in the obstetric practice that I won't actually belabor, but just this last one is all of the incentives are malaligned. That is to say, reimbursement's malaligned too. You get more money from some insurance companies if you do a C-section. And the doctor that does the delivery gets more money than the doctor that does the prenatal care. So if you're going to be off in the middle of the night when your covering doctor does the delivery, she gets the money. You did all the work. If you're not in the same group, the incentives are malaligned. So we looked at also some data on C-section rates. And I just want to show you some numbers. Dr. Paneth has probably seen these numbers, but I was just stunned. Now this is another oh my God slide, but I'm going to help you with it. We took a look at 1996 and 2004. The preterm birth rate, singletons, one baby in the uterus. We know there are more preterms among twins and triplets, so we just look at one baby in the uterus, singletons. And between these 2 years, there were 60,000 more singleton preterm births in the United States between 1996 and 2004. Now, if you look at the change in the number, the absolute increase of vaginal deliveries, there were 4,600. And if you look at the change in the number of cesareans, there were 54,000. 92% of the increase in singleton preterm babies between 1996 and 2004 are accounted for by cesarean delivery. Now, some of those babies might not need that cesarean. I don't know which ones. We think babies should be born at the right time for the right reason. But they shouldn't all be born by cesarean delivery. And we do know that it's very hard in the United States to get a vaginal birth after cesarean. This yellow curve is the numbers of vaginal births after cesarean. As the cesarean level goes up, if you've had one cesarean, you're going to always have one because it's going to be very hard to get one, even though the data show you can have a safe and effective vaginal birth after cesarean. It's very hard to come by in this country. So I'm going to move along now and tell you that we passed a bill in Congress called the Preemie Act. President Bush signed it, and Congress asked that prematurity become a public health primary concern. And we had a Surgeon General's conference in June of 2008 in which we looked at the question of an action plan for prematurity. And I'm not going to go through all of the recommendations from this Surgeon General's conference. They are available to you both on the Surgeon General's website and in an article published just this month in Obstetrics and Gynecology in which you can look at all of these recommendations. But there were 6 work groups that came out with action plans, and there were, I'm going to go to the conclusions. There were a set of conclusions. The number one conclusion was we need inter- or transdisciplinary research in this area, bringing together perinatal professionals, basic scientists, social scientists, translational and clinical researchers. And the March of Dimes has convened an expert group who have created a template for how we would recommend the National Institutes of Health implement these transdisciplinary research centers. And we are, on April 15th, meeting with the leaders at the NIH to talk about how we can bring together congressional dollars, executive office commitment, and the NIH to actually accomplish this goal. Stay tuned. There's also a whole set of other priorities that we think are quite important. We need good quality measures in this field, and we need to hold the doctors accountable on the obstetric side and on the neonatal side. Geography becomes destiny in this country frequently. We think in the neonatal world it ought to be the same. And we think in the obstetric world it's critical to hold the doctors accountable to ACOG standards. I forgot my number slides. If you really want to get depressed, look at the amount of money we've spent from the NIH budget on perinatal and pediatric issues. Very quickly, all the institutes have some money in children, but of course the Child Health Institute has most money in children. It's about $3.2 billion that we spend on children. And if you look at the NIH budget over this time, through till 2009, this was the doubling time. This was the time of the great growth of the research enterprise. It's not a chance occurrence that the change happens with the change in administration. And it's not a chance occurrence that the 2010 budget that President Obama has just brought forward has a 7% increase in the NIH budget. This will be the first increase in the NIH budget proposed by a president in 8 years. And in looking at the budget of the NIH, this is the pediatric funding. So it's kind of been flat. But if you look at it, and our colleagues Gitterman and Hay in Pediatric Research November 2008 took a look at a green line, which is the Biomedical Research and Development Price Index. So it's kind of a way of looking at inflation. This is what it costs to do research. And here's where we are. Both the NIH annual percent change and the pediatric annual percent change isn't even close to the normal cost of doing business. And then if we get even worse here, if we look at the funding for perinatal dollars, they're so low on this scale, these are billions, they don't even reach into the hundreds of millions. So we have a serious challenge in money. I'm going to go through that and go through that and just mention a couple things in closing. I started with the March of Dimes. I'd like to end with the March of Dimes. Each year in November, we do Prematurity Awareness Month, and we choose a day that we call Prematurity Awareness Day. We believe solutions are within our grasp. And in April, we're going to be marching for babies. And here I'm told in Milwaukee, it's April 25th, a Saturday. So we hope you'll be out marching and you'll be supporting the needs of these babies. But last November, we created the first report card, and we gave the U.S. a D. Now, how did we get this metric? Well, we asked the question, 2010 has a set of healthy people standards, which were created by the Department of Health and Human Services in the year 2000. They're aspirational goals. We're right now creating the 2020 goals, which will be announced in 2010. Well, what do you think the rate for prematurity was in the 2010 goals? I've told you the real rate is 12.8% or thereabouts. The aspirational goal for 2010 was 7.6. So we said, okay, that's what the U.S. said we should be at. We're at 12.8. So with simple calculations of standard deviations from that 7.6, we decided to create that as a metric. And that's how we came up with this map. Now, Vermont has 9%. It's the only state with a B. It didn't get to 7, but at least it was in the range as compared to everybody else. So we went to Vermont to try to figure it out. You could say, well, there are only 7 people in Vermont. They're all white and they're affluent. But even when you drill down more carefully, you find that Vermont has some interesting things. Every woman in Vermont is insured. Every obstetrician is part of a network of all of the obstetricians of Vermont who hold each other accountable for their practices. And the university has outreach in every hospital in that state. And the Department of Public Health has social services available for women when they need them. So if a pregnant woman has a drug addiction problem, she is fast-tracked into a program next day. Smoking cessation is done seriously. So Vermont has some things to teach us. And the South has some things to teach us too. If we look at Alabama, 24% of the women in Alabama are smoking in the child-rearing age. 26% are uninsured. This is a serious problem. And we can do something about those things. And we can hold people accountable. And the March of Dimes stands ready to work with you to look at evidence-based quality guidelines. We have an intervention program in Kentucky that we'll be telling all of you about at the end of 2009 as we develop our data on an intervention program in the state of Kentucky, which seems to be effective in decreasing preterm births, particularly late preterm births. We've got some new brochures, some new websites. We've created a brochure for women which basically politely sets out a set of questions that they might ask their obstetrician. Now, you know, there are women asking obstetricians for cesarean deliveries. Some of them are obstetricians. I'm not kidding. And when women request obstetric intervention, the American College of Obstetricians and Gynecologists says the obstetrician should really not accept that as a directive. That's the beginning of a conversation, not the end of a conversation. The American College of Obstetricians really has some good guidelines for obstetricians. The problem is that they don't hold their obstetricians accountable. They can't. But you can. You can at the hospital level through quality improvement. You can at the state level through task forces and interactions which demand to know about the cesarean section rates in hospitals and make those things transparent and public. You can in ways that really can impact in meaningful ways. What happened in Utah? When the Intermountain Health Program, which has 52,000 deliveries a year, they're the health insurer and they employ the docs around Salt Lake. They decided in 2002 that no baby will be born electively before 39 weeks. There will be no early inductions or cesarean deliveries before 39 weeks unless there is a clear medical indication. And they created that as a rule, and they empowered their nurses so that when the doctor called in to book the case, they had to actually explain to the nurse what the medical indication was, and if there wasn't a sufficient explanation, the nurse could send that obstetrician to the chief of obstetrics. And that chief had to approve those deliveries. The curve is so dramatic, it's unbelievable. It goes throughout 2000, 2001, 2002, and boom, the prematurity rate decreases by about 30%. And they've now published these data, as has the Hospital Corporation of America, as has Ascension Health, and other insurers looking at population-based data, and there are no increased adverse outcomes, there's no increase in stillbirth, there's no increase of problems, and Hospital Corporation of America said there were less lawsuits. Well, that was a trifecta. I mean, if you got better outcomes for the women and the babies and no lawsuits, you've won the problem. So we're out there telling hospitals we need good, solid accountability through quality improvement. We know how to do it. We call it safety. We call it performance. We call it quality. Let me end by saying that we at the March of Dimes join you in the Children's Hospital and the Research Institute in having a vision. The vision is that one day all babies will be born healthy, and together we can do that. Thank you.